I'm very glad to have the opportunity to present some interesting data and results we were able to obtain within our electrical stimulation study, which we performed in patients with facial paralysis. So we got some financial aids, especially for the electrical stimulation devices by Med-El from Austria and clinical research funds by the Interdisciplinary Center of Clinical Research in Jena. The aim of our study was to investigate the effect of electrical stimulation on denervated facial muscles in patients with complete facial paralysis. And thus we performed a prospective observational study designed as a pilot study to investigate in how far functional electrical stimulation would affect these denervated muscles. We included patients that had a complete peripheral facial paralysis, which was confirmed by needle EMG. And we had an observational interval of 1 year where the patients performed home-based electrical stimulation unless there would be kinds of serious adverse events or an event of renervation, because we solely wanted to investigate the role of the functional electrical stimulation which we performed, and not any altering caused by electrical signals due to insprouting nerval fibers. This is when patients were terminated from the study and statistics was just performed until the time of renervation. So to control and how far renervation occurred in the patients, we had 8 clinical follow-up visits, which were scheduled almost after every month. And there we performed that needle EMG and also electrical stimulation, where we set the parameters such as the voltage and the frequency each time new again, so that we had the optimal effects of the stimulation that would lead to the muscular contraction. There are some scores which we used for the assessment of the severity and the functionality of the face during facial paralysis, the Sunnybrook facial grading system, and the patient-reported outcome measures. And we also used ultrasound to analyze the cross-sectional area of the facial muscles, as well as standardized photography. For the ultrasound, we used an established protocol by Sauer et al., which allowed us to investigate nearly all important facial muscles. On the one side, innervated by the facial nerve, which would be affected after facial paralysis, such as the mental muscle, the depressor anguloris muscle, the zygomaticus muscle, which is the leading muscle for the smile movement, the elevation of the mouth corner, and the orbicularis muscle for the eye, as well as the frontal muscle. But also 2 muscles that are not innervated by the facial nerve, but the trigeminal nerve, which should not be affected by the facial paralysis as control muscles, such as the mesenteric muscle and the temporal muscle. For the photography, we took standardized frontal portraits in resting state, and afterwards we assessed the data in a program called Emotrix, which has the opportunity or is able to automatically compute facial metrics, and thus giving us some interesting surface parameters, such as the brow height, which is the distance between the pupil and the upper brow margin, as well as the palpebral fissure height, which is the distance between the lower and the upper eyelid, as well as the commissure height deviation, which is the vertical distance between both mouth corners, as well as commissure excursion and smile angle. For the electrical stimulation, we used 2 adhesive electrodes. One was placed at the lower jawline, and the second one was placed lateral to the nasolabial fold, because we wanted to solely stimulate the zygomaticus muscle, the muscle that was important for the elevation of the mouth corner, for the smiling act. And it is possible to solely stimulate this muscle according to a protocol published by Arnold et al. In 2021. We used 2-phase triangular waveforms, which are divided in a phase of salvos. You can see here and another phase of pause, and together they would create a 20-minute interval of training, which the patients would perform in the morning, afterwards followed by a minimum of 6 hours break and a second training session in the evening again for 20 minutes. And at the clinical follow-up visits, we would set the frequency, the voltage, and the phase duration at this level where we could see a clear contraction of the zygomaticus muscle, but while maintaining a still pleasantly tolerable feeling during electrostimulation for the patients. So here you can see the live stimulation of the zygomaticus muscle. You can see how far the zygomaticus elevates the mouth corner and the pause afterwards. So in fact, we were able to include 15 patients with complete paralysis in our study with different kinds of etiologies. Most of them were due to malign diseases leading to a facial paralysis, such as vestibular facial schwannoma, but also squamous cell carcinoma. And none of the patients had serious adverse events. And within this 1-year interval of observation, we saw 9 patients that had a renovation and were afterwards terminated from the study. First of all, we analyzed the scores that assess the severity of the facial paralysis. The Sunnybrook score is an objective score that is assessed by the physicians in order to evaluate on how far the face is functional still during facial paralysis. We started from a median value from 5 out of 100 points, going up to approximately nearly 40 out of 100 points within 1 year significantly, which was a great improvement. And beside that objective data by the physicians, what has been assessed, patients also could fill out forms how they subjectively feel how their body function or how their social function would improve. And even after 6 weeks, patients reported that there was a significant increase for body perception, but also social well-being. When we look at the cross-sectional areas of the muscles that we controlled with ultrasound, we have a decrease in muscles that have not been stimulated, such as the orbicularis oculi muscle and the orbicularis oris muscle. When we look at the stimulated muscle, zygomaticus, we can't find any decrease in that, which could be due to the electrical stimulation probably. We also have similar findings for our photographic surface parameters. We have the lid region, which has not been stimulated, and here we see an increase of the palpebral fissure height, which indicates that there's a worsening, since the lack of tension of the orbicularis oculi muscle would lead to a drop of the lower eyelid, whereas an area that has been stimulated, the mouth corner region, showed no significant worsening, and in fact shows a tendency towards symmetry in the end after approximately 8 months. So both the similar findings in the arrest of an increase of the mouth corner height difference, as well as the consistent cross-sectional area of the zygomaticus muscle, could show that there might be a direct effect of functional electrical stimulation that was solely performed on the zygomaticus muscle. And to conclude, we could successfully conduct a pilot study with a suiting study design for both the patient and the physicians in the clinic. There were no reported serious adverse events. And as you could see, there are first signs of an effective stop of atrophic behavior in muscles, especially in contrast to muscles that have not been stimulated and showed atrophic behavior. But what is definitely needed is a study that has more patients to get even more representative data, as well as a randomized controlled double-blind trial to get rid of other biases, definitely. And I would say from a personal point of view that a reduction of the clinical follow-ups maybe to a number of 4 or 5 would even make it more feasible or facilitate the study for the physicians, but also for the patients that came from even Germany or Switzerland and Sweden to our hospital just to get the clinical follow-ups. So that was my short presentation of the study. I thank you very much for your attention. Feel free to ask any questions that came up to your mind. Thanks a lot.